We're just waiting for people to populate the platform and then we'll get started. So just wait a few more minutes. Hi, Lee. Just the presenters. Can you see my slides? My slide? Great. Hi, everybody. We're still waiting for people to populate. There's quite a number of hundreds of people that have registered, so it takes a few minutes for folks to get on the platform. It will just be another minute. Okay, we're going to get started. As people continue to come in, they'll play catch up. Thank you so much for joining our briefing today. This briefing is on building infrastructure to implement programs that promote healthy development and prevent behavioral problems and mental health problems in our youth. My name is Dr. Diana Fishbein. Everybody calls me Denny, so that speakers might refer to me as such. I'm a senior scientist at the Frank Porter Graham Child Development Institute at UNC in Chapel Hill, University of North Carolina in Chapel Hill. I'm also part-time research faculty at Penn State University, and I'm president of the National Prevention Science Coalition to Improve Lives. And it's the coalition that is sponsoring this briefing. The coalition was founded nearly a decade ago as the very first organization in the United States to translate knowledge and practices amassed from the prevention sciences into public health policy. And it has quickly grown to over 1,000 members with expertise from across a wide range of disciplines relevant to prevention. We work at the national level to inform Congress and agency officials about the science and its relevance to public policy, and with states and local communities to encourage and guide implementation of preventative measures. Our other briefing sponsor is the Edna Bennett Pierce Prevention Research Center at Penn State University. So why is it important to build infrastructure for primary prevention services in our communities? The basic premise behind this briefing is that the greatest gains can be made by providing community-based infrastructure to support the delivery of well-tested primary prevention strategies for two purposes. I'm going to start with the second purpose, which is to work to mitigate the negative effects of adverse social conditions on children, families, and communities. And again, I consider that the second line of defense because the first line of defense is to reduce exposure to the aggravating conditions or the root causes in the first place. Both approaches are the bread and butter of prevention science, and as a subdiscipline of public health, the aim is to eradicate risk factors and attenuate their negative impacts in the population served. And just as importantly, on the flip side, prevention scientists develop strategies that foster protective and positive conditions that are conducive to healthy social, mental, academic, and physical health. And given the substantial body of knowledge that's been amassed in the arsenal of evidence-based practices that the science has generated, there are huge opportunities for prevention scientists to work in concert with state and local officials, human services systems, community stakeholders, and providers to integrate these practices into their policies and procedures. So just quickly, these are the number of activities that prevention scientists engage in, and each one is conducted at all levels of the prevention model that frames this briefing. This is in this figure is a depiction of the risk and protective factors, just a sampling at each level: child, family, service systems, life events, and societal level that impact our behavior and ultimate outcomes. And so scientists work to identify the risks that can be reduced and protective factors that can be strengthened. They also develop and assess the effectiveness of these programs and policies. They determine best practices for implementation, and I call attention to the Impact Center, but also see the Epicenter. The Impact Center is at UNC. The Epicenter is at Penn State University for implementation protocols that have been shown to work. And then they identify optimal means for dissemination and scaling. And finally, and as I said, our coalition is one of the first actually, to begin to form policymaking with what we know from prevention science. This is from the National Academies of Sciences 2019 report, and it's a figure that shows that the activities of prevention scientists have led to the generation of a strong evidence base for developmentally oriented interventions, starting early in life, even prenatally, and going through early childhood into young adulthood. And so you can see the different kind of genres of programs that have been developed. And as you get down to the bottom, you see community interventions that cross the entire lifespan that are not just ways to strengthen communities, but also address poverty, violence, addiction, discrimination, and social isolation. And then at the very bottom, policy, which affects us all throughout our lifespan, is absolutely key. So this indicates that there are multiple opportunities for intervention across a young person's developmental course. The success of this agenda of prevention science is really remarkable. The successes are really, really significant, but they're insufficient because the focus on interventions alone will never achieve population level effects. Ideally, a given intervention wouldn't be delivered in isolation, but within a broader network of a community system of supports. The constraint has been throughout this time of prevention scientists, conducting their implementation protocols, and there's been a lack of infrastructure to scaffold and support the systematic and ongoing implementation of these interventions to ensure that they are scaled and that they are sustained over time. There's something like over 3,100 counties in this country, and very few of them have infrastructure for prevention. So we go here to the need for infrastructure, which is what this briefing is about. To deliver measurable benefits on a population level, evidence-based services need to be integrated into all sectors of our communities and supported by solid infrastructure and prevention-friendly policies. That sort of approach will help us to build a comprehensive continuum of services that will help us to increase individual resilience and capacity of families, to improve overall well-being and reduce the prevalence of detrimental social conditions, and then finally prevent formal systems involvement in child welfare systems, and so on. So in this services system, many of these prevention practices can be provided widely and voluntarily to anyone who lives in the community. They're place-based and they're centrally located to ensure accessibility, and they align with community values, norms, and cultures. To be successful, a strong network of partners and a shared vision are necessary. No single agency can do this work alone. Partners must also include community stakeholders, policymakers, practitioners, and scientists. And this kind of cross-sector collaboration around the express needs of families and communities can lay a strong foundation for broad improvements in the key indicators of family and community well-being. Once all of these conditions are met for a comprehensive, community-based collaborative system, the science can then direct us towards best practices, programs shown to work, implementation guidelines, coalition building strategies, and other approaches to leverage community resources and supports. And the result then is the co-creation of child and family well-being systems that meet the needs of all of its recipients. So now to housekeeping. So the virtual platform enables many more participants in our in-person briefings that we've held in the past. So we appreciate your patience with any technical difficulties we may experience, which seem to be almost inevitable. Just to let you know, only the panelists will see comments submitted to the chat. So please do feel free to chat. I did try to change the setting before the briefing so that people could chat with one another. And so that may be possible if I did it correctly. But also please know that we as panelists can't follow all the inputs into the chat. So if you have questions for us that you want us to address, then please submit those to the Q&A in your platform. Also, I want to let you know that the briefing and accompanying resources will appear on our website about a week or so after this briefing. So everybody who registered will get this recording and all resources associated with it. And all of our other briefings and all kinds of resources and good information is at the website that you see linked here under our housekeeping helpers. So these are our speakers. Dr. Abby, if I can, Fagan, Dr. Zili Sloboda, Dr. Peckley, Lisa Hill, and Ileana Lee. And so each of them will be picking up a piece of the pie and talking to you about what it takes to build infrastructure and then what it looks like from a real world view. Lisa Hill in particular will give us that real world view. She is the CEO of Invest in Kids, which is an amazing organization that brings all this groundwork that has been laid to life. And then Ileana Lee will bring community voice into this. So from the state level to communities to the family, so there is full engagement throughout the, all the different levels of expertise that we have reflected here. And so I'm going to stop my share and send it over to Abby Fagan to pick this up with her slides.
Okay. And you all see my slides?
Yes, ma'am.
Great. Okay. Well, I want to thank Danny and the National Prevention Science Coalition for organizing this panel. I'm excited to be part of it and to hear what our other speakers have to say. And I want to thank all of our attendees, and I welcome your questions and comments at the end. So Denny has already talked about why we're having this panel. The exciting news is that after many years of research and testing, we do have many effective prevention programs, policies, and practices that have been shown the ability to prevent behavioral and mental health outcomes. And they're ready to be scaled up and to be put into use more widely across the country. But we know that that's not happening currently, and we need more work to figure out how to scale up so that we do have those population level impacts that Denny mentioned. I'm going to be talking to you about work that I engaged in with colleagues who are affiliated with the Society for Prevention Research. Some of you may know this organization. We are a multidisciplinary group of academics, policymakers, practitioners who are all focused on advancing the investigation of the causes and prevention of problems and translating that information to promote health and well-being broadly. Now, back in 2016, our organization recognized that we have this problem where we are not scaling up the evidence-based interventions that currently exist. And so they charged a work group, which I co-led with Brian Bumbarger, to try to figure out what do we do about this problem. It was a little bit of a daunting challenge, but we had some great minds that we put to work on this. This slide shows the members of our task force. We also had additional participants who I'll acknowledge at the end of the talk. After considering a lot of different possible answers to the question of how do we scale up interventions, we decided to focus on public systems, especially the public systems in the US that are most responsible for using evidence-based interventions that promote positive outcomes for young people. So juvenile justice, public health, behavioral health, education, and child welfare. And we thought about focusing on community level factors, but ultimately decided to look at these public systems because they are the ones who, where the rubber meets the road, they will be the ones who fund these interventions and in many cases are charged with implementing them. And they have a dedicated infrastructure with leaders and workers built into them and resources. But we suspected that there might be some barriers that hinder their ability to fully scale up interventions. And so we broke into separate tasks. Well, we broke into five separate groups. We were each charged with looking at each one of these systems. And we invited some additional colleagues to brainstorm with us. What are the barriers that exist within those systems, and what are the facilitators within those systems that might affect scale up? And then where the barriers exist, how do we provide some recommendations for overcoming them? Interestingly enough, although we worked independently on this job, we came up with a very common set of facilitators and barriers that seem to exist across these five systems. So I'm going to review with you most of the barriers and facilitators that we've come up with, but I will also provide you with a link at the end to a paper that we wrote on this topic and some policy briefs, so you can look there for more information. So first and foremost, although many of us who work in the field of prevention science are aware that we have made progress and we have a list of many different evidence-based interventions, that knowledge has not been widely shared with practitioners, with policymakers, and members of the general public. And so how do we get the word out about what works? Well, one facilitator is that we have many different clearinghouses or registries, one of which will be mentioned today by Pam Buckley, Blueprints for Healthy Youth Development, but you might be aware of things like Crime Solutions, which lists criminology and criminal justice interventions, or the What Works Clearinghouse in Education. Essentially, these are websites that list evidence-based practices, and they try to do so in a user-friendly manner that talks about what it takes to implement these programs. So they are a great resource for communities and systems that want to use something that has evidence behind it. However, these websites themselves are not widely known to everybody who should know about them. And sometimes they don't have all of the details about implementation and what it takes to put one of these interventions into practice. And so many people have called for making them more detailed and even more user-friendly. We also know that for community agencies to make full use of these registries, there oftentimes needs to be some additional support. And fortunately, many of our states and some other organizations have created what we call intermediary organizations that are designed with this goal in mind, to work with communities to help them find out what works and to implement these strategies with quality. Denny mentioned the Impact Center at UNC, the Epicenter at Penn State University. Those are some examples. Now, within public systems, we know that the leaders make a huge difference into what happens and what the quality of that work is. And when we have very active, engaged leaders who know about evidence-based interventions and fully support them, that is a huge facilitator of scaling them up. They can direct resources towards those types of interventions, and they can motivate the workforce to use them. However, oftentimes leaders don't have that awareness. They need some education around what works. Turnover in many of these state level positions is high for various reasons. And so you might have a supportive leader who moves on to a different position, and then we have to start all over again. And so our group was thinking about, one strategy for enhancing the supports of leaders is to develop leadership academies, places where leaders can go to find out information about what works and what are good implementation strategies. As one example, in behavioral health, NASADAD, the National Association of State Alcohol and Drug Abuse Directors, has created a prevention arm called the NPN, or the National Prevention Network, that hosts conferences that are well attended by directors and leaders who work within behavioral health. And annually, these conferences talk about effective drug and alcohol prevention strategies. Of course, leaders can only do so much. It's the staff on the ground who will be ultimately charged with implementation. And we know that systems are notoriously understaffed and under-resourced. And so having enough staff who are, like leaders, aware of evidence-based interventions, committed to making them work, and supporting those, that will facilitate scale up, probably like nothing else. But unfortunately, many staff do not have that knowledge. We're only now creating advanced degree programs in prevention science that will train folks to go directly into this workforce. But most people on the ground have had to pick up this knowledge wherever they can, and it may be incomplete. And we know that the knowledge is constantly changing as new things are developed and adapted for use. And so we need we need less turnover in staff, and we need more education for workforce about these strategies. This includes both pre-service and in-service training. That in-service training is also very important. Once implementation starts and barriers and challenges creep in, folks need support to get back on track sometimes and figure out how to reach the populations with the services that are evidence-based. We also know that tracking implementation practices and outcomes is very important, and that when you have user-friendly systems where people can input these data and track them over time, it helps to ensure high quality implementation so that if barriers are happening, they are noted and can be understood and hopefully addressed. And accountability. You want to make sure that the practices you're using are having their intended effects on participants. The problem is, again, some of the times our systems do not have user-friendly tracking systems. Sometimes the information that's being asked is not necessarily the most important. And if you're working with populations that span multiple systems, it would also be nice to have these data systems that can be linked across systems. You also need people with expertise in how to analyze the data and feed it back to those on the ground to make changes where necessary. And that is not always the case in our public systems. So the recommendation here is for systems to invest more in their data collection systems and providing more staff who can work with those data and analyze them. Last but not least, we did definitely want to acknowledge the role of community in implementation and scaling up of evidence-based interventions. We know that every community is different. Denny mentioned how many counties we have in the US. The number of discrete communities is an exponential number from there. And communities need some assistance in figuring out what is going to work with them. Work for them in their community. And they can also provide some accountability to the public systems. They can demand that systems implement evidence-based interventions, and they can, in some cases, help track the quality of those programs and increase demand for them from the public. And to recognize this, some of our federal initiatives like SAMHSA's strategic plan framework and ONDCP's drug-free communities have provided resources to communities to create local coalitions of folks who are supportive of promoting healthy development and who work together to select the right interventions for that community and help ensure that they are implemented in ways that really engage their audiences. But community coalitions can also be tricky. They oftentimes are under-resourced and they need assistance to do the work that they're charged with. And so we need even more funding mechanisms like the DFCs that can help sustain these coalitions. Last but not least, this is really falls outside of the systems to some case because it's really a federal issue, but of course, what's really helpful, and in fact, the factor that we felt was most important is when there are federal mandates to use evidence-based interventions. This is coming along, and we have had some examples over the past decade or two, like the maternal infant health funding that was started, I believe, with President Obama, the Head Start Act. Those can be very useful for scaling up. However, sometimes those statutes are not, what they tend to do is they say we require evidence-based interventions, but how they define what is evidence-based is sometimes not very clear. It might be overly rigorous or it might not be rigorous enough. So they're funding things that may or may not actually have evidence behind them. And so our recommendation is let's keep doing this, but let's get a little bit more clarity and consistency on what it means to be an evidence-based intervention. And then we need to fund those statutes as well. So instead of just mandating that systems use these things, we have to provide some funding for them. It's very helpful when we have these block grants and categorical grants that are set aside for evidence-based interventions. But sometimes, again, those grants don't actually require the use of evidence-based interventions. So we'd like to see a little bit more specificity in how those monies are handed out, but also recognize that we need some discretionary funds too to help develop more innovative interventions and help build that repertoire of what works. Okay, so I'm going to leave it at that. And I just want to acknowledge again, we did have some funding from the National Institute on Drug Abuse to do this work. And we had a few other members who were involved in our project that I want to acknowledge here, especially Belinda Sims, Deb Gorman Smith, and Hendrix Brown. And then if you want more information, Denny will be sharing this slides set with you later, but you can look for our paper published in Prevention Science Journal, as well as the policy briefs, which are all free of charge on the Society for Prevention Research website. Thank you.
Thank you so much, Abby. That was great. Great framing for the whole rest of the briefing and very good concretized information. I apologize for not introducing you, but since you pretty much did it for yourself, I'll just, go ahead and introduce Zilly at this time, who's going to be speaking next. So she is trained in medical sociology, mental health, and epidemiology, and she's the CEO of Applied Prevention Science International. Her research is focused on substance use epidemiology services research and the evaluation of treatment and prevention programs. Her current focus is on the prevention workforce development and the relationship between training and the implementation of evidence-based preventive interventions and policies. She has also worked at the National Institute on Drug Abuse in several capacities, including as the director of the Division of Epidemiology and Prevention Research, and she was the founder of the US and the European Union Societies for Prevention Research. And this could go on and on for many pages if I were really to tell you all of her credentials, but I will let her speak for herself. Thanks, Zilly.
Thanks, Jenny. Let's see if I'm smart enough to share my screen. I can't believe it.
Oh, there we go. Perfect.
Okay, and thanks so much. And Abby, thank you so much. That was a wonderful presentation and summary of where we are to date. But I'm going to be talking about and presenting a concept that Denny and I have been working on for, I don't know, forever, it seems, which pulls almost everything that Abby talked about together into this concept of a community-based prevention service delivery system. Now, if I can only change the slides, that would be good, wouldn't it? Oh, I wonder why it's not moving. Oh, lovely. I told you.
All right, maybe, do you see the arrows at the bottom?
Oh, yes, now I see that just came up.
Yeah,
They just came
yeah.
up. Yeah, thank you. Yeah, I was looking for them
Right.
and they were there.
Right.
Denny and I published this paper at the end in December. That's sort of it covers everything that I'm presenting today, and so you can have access to that. I think that's going to be part of the resources right at the end of the session. Great. Okay. So you've heard this already. We've made a great deal of progress, and it's an understanding the underpinnings, pathways, not only to substance use, but to a number of other behaviors. And that's really important. And I want to underscore also that these same interactions, the same pathways aren't just in childhood, but they occur across the lifespan. I myself have been retired 110 times, I think. And I, every time my life changes, and there are definitely different influences on how I do things and on a number of other issues. So this isn't a stagnant thing. This is a dynamic activity, and that's why we need to have interventions across the lifespan. I think what's really important is to understand, as both Denny talked about and Abby, is that we are influenced by a number of outside forces, principally, of course, at the micro level environments, our family, our schools, our peers across the lifetime again, faith-based community, workplace. One could add a whole, now we can talk about social information systems, but also from the macro level, we're influenced by what's going on with us. The big challenge that we in the prevention field are trying to wrap ourselves around now is climate change. There is a survey, has been an international survey of young people and they have a great deal of anxiety about climate change and what their future is going to look like. And so prevention professionals are beginning to look at that issue. So that influences how we behave, influences our beliefs, our attitudes, norms, and ultimately our behavior. I consider this a socialization process. And as I said, it's very dynamic. Let me just say that this also, I forgot the stars. What's really important is I want to emphasize is that because of this whole process, this dynamic nature and the multiple components that influence our behaviors, that we really need interventions at all these different points of time. So we need a comprehensive system of services. The problem is, of course, I think when I was at NIDA, we used to use this term all the time, the big disconnect. That was my biggest frustration, I think, when I was there, because we had all this great research and how to get that research from research settings to the community. And that is the challenge that we have, as Abby emphasized very nicely. So one of the solutions that we suggest is that that not only to address deliver evidence-based prevention interventions and policy, but we have to assure the quality of the services and also the equity of the services so that everybody that needs the services will get them. And we think that the creation of a national community-based comprehensive prevention service delivery system is the answer. What would this look like? It's complex, of course. That any of you that know me, I only think complexity. So this is what our idea of what the system will look like. You can see there are multiple components. At the heart of it is, of course, the delivery of services, evidence-based services that are delivered by certified prevention and trained prevention service providers, and that they address all those elements in our community that be community-based. But as Abby points out, that there needs to be a monitoring evaluation system to support the delivery. You're going to hear me talk about systems. I've went through my text. I was going to cross all the words out, but I think it's important to emphasize we're talking about a system, a dynamic system. And that we, as mentioned also earlier, that these services come not only are direct from prevention providers in the community, but they're also occur in other systems. And then overseeing all this would be oversight and funding. So what would the components be in more detail? First is having this is my bias, I'm an epidemiologist at heart. First is having the data to guide who is vulnerable, the types of services that are needed, as well as a monitoring system to determine if these services are met and to what extent they're met. We also would have, as mentioned, this system would provide appropriate, and I emphasize appropriate because we have to match need to the intervention, but they would be appropriate evidence-based prevention interventions and policies that would be delivered with fidelity to meet the needs of the community. And given our understanding of the etiology of the behaviors of interest, the system would have to have multiple services that would address parenting and family management issues, school and workplace challenges, etc. This would be really important. They have to be in sync to support each other. And community policies need to be in place, and I think Denny reinforced that on her opening statements. We have to have policies on the ground to support these interventions, and that create a safe and healthy neighborhood for our community. And a particular interest to us is having trained prevention professionals to coordinate and deliver prevention services. And we identify 3 types of prevention practitioners. There are those who self-identify as prevention professionals, but then there are prevention professionals, practitioners who do not self-identify as prevention professionals, and yet they're doing prevention work. These would be social workers, family service professionals, healthcare workers, and educators. And then it's important that we have students of prevention science to track the practice and to continue doing the research. One of the things I'm finding, because as Denny mentioned, I have the president of a company called Applied Prevention Science International, and we are international. We've been doing training of prevention practitioners on the ground around the world. And what we're finding is that they don't share the same knowledge, skills, or competencies. And that's why training is important, that we have a cadre of professionals who share knowledge, even terminology. As we know in the prevention field, that's a big challenge, but also the same skills and competencies. It's really significant in that they are complete in that knowledge and skills. We also need to have an oversight component to the system that would assure that the quality and particularly equity of service delivery. That can't be emphasized enough. And then, of course, we talk over and over again in the field of prevention that we don't have adequate funding to meet service needs. And we need to really do more on cost efficiency and effectiveness. And my own bias here is that we have health economists to look at these cost benefits, cost effectiveness of prevention services. I think we need to develop our own model of what we really want to look at. The health economics model doesn't always apply. So think about it. This is my dream, is having a national system building on community coalitions and partnerships that we have already in place that deliver these evidence-based programs, and they deliver them with quality. It's really exciting. And then we would have this system, but it would have an oversight from federal and state groups. We just put this together. We could add other things, but I think also what's important is not only to have this oversight, but also to have an ongoing review by key leadership groups to make sure that we're constantly having the best services delivered to people who need them. And as Abby already mentioned, we have a whole bunch of stuff in place already. So we have a good starting point to create this system. We have epidemiologic data sets at the national and state level. We have evidence-based services that we talked about, and that Pam is going to be talking about more. We're doing training of prevention professionals at a number of universities across the country and internationally are offering courses in prevention science and degrees. Credentialing and licensing is also beginning. The International Certification Reciprocity Coalition is working in the United States with the Department of Labor to actually get a code for prevention professionals, which I think is really exciting because it does professionalize the field. And of course, we want funding that's consistent and adequate, or I guess adequate and consistent. And we have taken steps towards building a comprehensive prevention service delivery system. Steps have already been taken. We recommended in our paper to have a national group come together, to an independent group that would come together and actually talk about what we have available and what this community service delivery system would look like. And we feel that the Blueprints project that under the National Academy of Sciences is initiating such an effort. We would like to have, once that a paper comes out, a white paper or whatever is planned, that would be expanded to include more stakeholders, to hear more voices, that there would be development of training and technical assistive protocols to continue professionalizing the prevention and our treatment workforce, to build community level assessment systems. We do have, as Abby mentioned, we have a number of community partnerships and coalitions across the country. I've talked to a number of them. They are struggling. Not all of them. Some of them are doing very well, but there's constant changes in the community that impact their work, and I think that they really need some help in that regard. We need to build and strengthen them. And then, of course, we need to work towards developing a community prevention and treatment infrastructure. And I talk about treatment, and actually, Denny and I are working on a follow-up paper. I'm building big builder, a community delivery system that goes from prevention through to recovery and to actually harm reduction, also, which would include treatment. And then, of course, there is a lot of work that's being done on building a viable prevention workforce that I mentioned. Oh, I'm sorry, I'm going backwards. As I said, there's a lot going on in this area. I think it's a little diffuse. It'd be nice if we had somebody sort of overseeing what's going on at the national level on training. There are a number of training programs out there, but they're not necessarily training in the same areas. Repeating the same thing. Anyway, thank you for attention, and please, hope you have a chance to get access to that paper and review it. Thank you very much.
Thank you so much, Zilly. That was phenomenal, as usual.
Not really.
And no, it was great. And in the background, I performed a great feat of getting chat to work. And so I know, it's an important way of feeling a sense of community during these webinars, and that I'm sorry to have taken that away from you for about a half an hour. It turned out to be very easy. So anyway, I did everything complicated. The solution was easy. So I'm now going to introduce Dr. Pamela Buckley. She is an associate research professor at the University of Colorado in Boulder. Her scholarship focuses on interdisciplinary and applied research to understand what works for whom and in what settings, and in generating reliable evidence for preventing negative outcomes and fostering well-being for youth. She is interested in advancing scientific understanding of evidence-based preventive interventions that support youth from historically marginalized populations. Take it away, Pam.
Right, that's my cue. Thank you so much, Denny, and thank you for everyone being here. And it's hard when you have all these things on your screen to try and get this into, here we go, from the beginning. Can you all see that?
Yes.
Okay, so I'm here and I'm thrilled to be here. I'm thrilled to be part of this team. I'm going to be really brief because I think there's just some really interesting information to come after this too, in terms of what our last two panelists have to say. I am going to, yes.
Yeah, you are not on the slideshow. You're this, we can you go to like slideshow?
I was from my computer. I am.
Yeah, full slides. Like we could see, the thumbnails of the slides on the side.
Yeah, see, I had it in slideshow view, so we'll try it this way. And let me know, is this better? No?
It hasn't come through yet.
I'm also out of town right now and on vacation, and I'm in a place where my Wi-Fi I'm not as certain about. So that could be some of the challenges here too.
Well, darn, it came right up initially.
Well, Like I was saying, we've got two great, fabulous presentations following this. I'm going to briefly tie into, if you can see my slides at some point, briefly tap into giving concrete examples of what Zilly and Abby have discussed so far.
Try it again, try it
Okay.
again.
I'm
Yeah,
gonna try one more time. And thank you everyone for your patience. I'm sure many of you have been in these shoes where you're doing a webinar and something's not working. So
always,
you learn to
something.
improvise.
yeah.
Still can't see it?
Do you want to have Denny pull it up instead? And
Yeah, why don't you go ahead and do it, Denny?
Oh, sure. Give me 1 sec and I will get this going here. So I'm gonna slide share. And let me know if this is coming across.
Yes, it's great.
Perfect,
All right. This is a true tag team effort. Okay.
yes.
So my name is Pamela Buckley. I'm with the University of Colorado Boulder, and I'm here to talk about how to find information online in terms of these evidence-based preventive interventions. Next slide. So what are evidence-based interventions? A little level setting to do some definitions. They are interventions that have been rigorously tested, proven effective, and translated importantly into models available to community-based intervention or based organizations. And these evaluations have been subject to critical peer review by experts in the field who have examined the evaluation's methods and agreed with its conclusions about the intervention's results. Next slide. So how do we go about finding these evidence-based interventions? There are many tools out there. One tool that exists are what we call online clearinghouses that essentially they translate the evidence, they synthesize it, and they use according to published standards of evidence to identify effective interventions. They focus on results of high quality research to answer the question, what works? And from that, they generate an inventory of evidence-based interventions. And there are many around there, up to 24 in the United States and Europe alone. And they can be high stakes in that funders can use this information to inform decisions about allocating prevention dollars at both the federal, state, and local level. Here is a slide that Abby talked about. And what I'm going to focus on is highlighting that first piece, the facilitator piece. Let's go ahead and circle that, Denny, for me. And I'm going to give you some examples. So if we go to the next slide, I mentioned there are up to 24 registries in the or around the world. And here in the United States, we have several funded through the US federal government. These are up to 5, 6 examples. And I want to draw your attention, Zilly or Denny, if you could just click again to that last column. And the focus of each of these different registries is really outcome specific to whatever that agency is focused on. And if you can go ahead and click 2 more times, please. And then SAMHSA had a national, the NREP registry that launched in 1995 and suspended in 2018. And the outcome focus was on substance use and mental health disorders. And then if you go to the next slide, there's another registry that I help run. And it's called Blueprints for Healthy Youth Development. Its goal is to provide communities, policymakers, agencies, and researchers with a trusted guide to youth prevention programs that work. And I highlight trusted. If you click again, my elevator pitch is we talk about we're like the Consumer Reports Guide. I talk about refrigerators being expensive. I don't want to spend the brain damage of trying to figure out which one's the best one. So I go to the Consumer Reports Guide. I trust the science or trust the information they're putting within their registry, similar to Blueprints. We're using high standards to look at the evidence and provide recommendations on how to disseminate evidence-based interventions at scale. Next slide. So I want to give you a definition here in terms of upstream prevention. And what we know is that go ahead and click 3 times, please, Denny. 30 years of prevention research shows it is possible to reduce negative health outcomes, including violence, suicide, and substance misuse before they ever start. And determining and addressing the root causes and conditions that contribute to negative health outcomes is known as upstream prevention. And the goal of upstream prevention is to build resilience, decrease risk factors, and build protective factors to have impacts on individual and public health downstream. So as the population ages. And if you click again, Denny, please. So Blueprints provides a registry of effective upstream prevention evidence-based interventions. And these are all interventions that can be implemented depending on the need at either the individual level, the family level, the school and community level. And the goal of the intention or these programs have been proven to improve child development, support families, and enhance school experience. Next slide. So quickly, Blueprint started in 1996 by Dr. Del Elliott. We have reviewed 2,900 studies and 1,600 programs, and 113 have met Blueprint standards to date. We did get a question about this in the chat. As of July 1st, 2024, Blueprints actually will not be updating our website until additional funding is secured. So to Zillie's point in the previous presentation, we need adequate and sustained funding. However, it's important that everyone know that this registry will still remain online, so we won't be updating it after the 1st of July until funding is secured. However, the information will stay and you will be able to access the information. And if you want more information, you can go to our homepage at our website to read more about this announcement. Next slide. So Zillie had this amazing schematic that she and Denny put together about what an infrastructure could look like for a prevention system. And Denny, if you could just click maybe 1, 2, 3. This is the hard part of having an animated slide that you don't control, and 4 times. Thank you. So what I have here is to show you within this ecosphere where these online tools, registries exist, and how they can be one tool to help consumers look for information on these evidence-based interventions and practices. Next slide, please. So this is then drawing on a point that Zillie made previously. So how to access the need for this infrastructure is for consumers to be able to access evidence-based interventions in micro-level environments to include parenting and family skills that enhance parenting practice, enhance family communications and support, and go ahead and click again, and have school programs that create safe and supportive school experiences to include school climate, enhance performance skills, enhance life skills. And then if you click again, these are all examples of the kinds of programs you can provide you can locate on the Blueprints registry. Next slide. Here is another one of Abby's fabulous slides. And I now want to focus on that last piece of recommendation. If you could click again, Denny, and then go to the next slide. And I'm going to give you some examples. Now, I'm going to tee this up for the next 2 presenters because this is what they're going to talk about. Invest in Kids is an example of a statewide public and private initiative. And go ahead and click a couple more times. They actually have legislation that they've passed in the state of Colorado to enable communities to be able to scale programs that they're implementing, so they can take a state funded program and then match it with state funds and private funds in order to scale up these interventions. And there are the 3 that they're scaling up are actually located on the Blueprints registry. Lisa and Ileana will speak more about this. Next slide. Here's another example of actually philanthropy working with community partnerships to scale up evidence-based interventions. And Denny, go ahead and click probably 4 times. So what they do through, oops, too much, but quickly, what they do is they bring together assessment and to understand how children are doing. And then they select interventions with communities, and they develop financing action plans to support the ongoing use of these proven programs. And I've highlighted from their website how Blueprints is one of the resources to help consumers find these evidence-based interventions. Go ahead and click to the next slide. So quickly, I've been doing this for a very long time, and there are 3 questions I typically get, and that informs my thinking and how it's evolved over time. First, I want to highlight studies to express 3 themes. 1, the need to harmonize across clearinghouses, because there is confusion over ratings. I get this question all the time, and they're valid. I'm not going to address that now. If you are interested in that topic, you can follow up with me directly. I have lots of resources for you. The second is, and I'm going to talk a little more about this, how to expand the question of what works, which is super important, to also consider for whom and what settings, so we can do a better job at matching community needs to these services and make sure that we are equitably serving the needs of communities. And third being, outreach is needed to enhance uptake of EBIs, and Zillie really did talk about that with the prevention workforce, etc. So I'm not going to focus on that right now. So go ahead and advance to, I'm going to talk about this, what works for whom and what settings. So if you could please advance to the next slide. This is a paper that I published with my peers, Racial and Ethnic Representation in Prevention Intervention Research, a Methodological Study in 2023. If you could click on the next slide. Thank you, Denny. So what we did is we looked at 885 prevention programs, and they had evaluations published across 11 years from 2010 to 2021. And let me tell you what we found. So we can click to the next slide or the next. Thank you. You can click 3 times, please. So we had some key findings, but I want to, before I go through these findings, draw your attention to the blue font at the beginning or at the bottom of the slide where it says culturally grounded. And what I mean by culturally grounded interventions, those are those that are co-designed between the community and the researcher, co-evaluated with a specific culture in mind to reflect the values, behaviors, and norms of the target population. This is so important when we think about issues of equity. So in that examination of 885 programs, we found that very few, only 2% were culturally grounded specific for Black or African American youth, and only 4% of these programs were culturally grounded for Hispanic or Latino youth. So that's thinking about the program design element. I now want to shift your attention towards thinking about generalizability, and that means looking at the sample demographics. Who is represented in these studies where these evaluations are being conducted of these evidence-based interventions? And what we found is across these 885 programs, only 77% of studies reported race. Now that should be 100%. So of the 77%, just over a third of the enrollees were white, under third, 28% were Black or African American, and importantly, 31% collapsed across racial categories or categorized race with ethnicity. Another finding we looked at is 64% of the program's evaluations reported ethnicity. Again, that should be 100%. And of those that reported, about a third of the enrollees were Hispanic or Latino. So what does this mean for the field? The conclusions are we need more culturally grounded evidence-based prevention interventions. We also need better reporting so we can advance programs that reduce racial disparities to determine, and also to determine whether communities with unique demographic features have been studied. And finally, I think that's it. Thank you. And thank you, Denny, for orchestrating this.
Absolutely. I'm so glad it worked out. Thank you so much. That was brilliant. And so now we're going to Lisa Hill. She's the president and CEO of Invest in Kids. Her work is towards smart investments in children. Lisa leads a highly functioning and strategic organization that brings research-based, proven programs to communities across Colorado. Invest in Kids efforts focus on the specific needs of children living in under-resourced communities whose families are experiencing poverty, with the hope of seeing every child in Colorado thrive. She furthers the organization's impact by inspiring her team of professionals and through her focus on advocacy, strategy, finance, board management, fundraising, and program delivery. Otherwise, she has nothing to do. Take it away.
Thank you so much, Denny. Thank you all. It's an absolute honor to be here today, and I'm really grateful to have been asked to participate. I'm going to jump right in and make sure that my screen's going with you. Are we good? Okay. So when Invest in Kids was founded in 1998, it was because a very dedicated group of community leaders, mostly attorneys doing pro bono work, watched and saw that their clients, who were Colorado families, were experiencing poverty and living in under-resourced communities. And they were parenting young children without access to adequate voluntary prevention programming, speaking of the value of working upstream. So partnering with local communities to bridge the gap between evidence-based programs with proven effectiveness and communities who had a desire to deliver those programs, Invest in Kids was born, and the mission remains the same, true to today. I want to acknowledge, as we get started, about our commitment to equity. Invest in Kids very much recognizes the toxic impact of oppressive forces like poverty and racism on Colorado's children and families, and therefore our commitment is to dedicate our time to building a future where we can no longer predict. child and family outcomes such as healthy pregnancies, child development, and school readiness based on socioeconomic status, race, ethnicity, or location. I'm here today to talk about our approach at Investing Kids. And so we're going to walk through all of these about the identification of programs, the science of implementation, how we advocate for sustainable fundings, and what we're doing here today, which is sharing our learnings. So our 3 programs, which Pam briefly mentioned from the Blueprints Registry, one that we adopted early on, which is the Nurse Family Partnership, a nurse home visitation program for first-time pregnant people and their children. Public health nurses working with them from as early as possible in their infancy through their child's 2nd birthday, focusing on healthy pregnancy outcomes, child health and development, and the parent's long-term self-sufficiency. In 2002, we chose the Incredible Years, which is a suite of prevention programs designed to increase a child's social competence, both at school and at home, working with teachers, parents, and the children. And then just in 2020, actually, in March of 2020, which we all know how hectic that month was, we chose to adopt Child First, which is an early childhood mental health intervention, working with young families, providing intensive home-based services, actually with a care manager, as well as mental health clinicians. So 2 people providing supports to families with young children experiencing chronic stress and trauma. So those are the 3 programs for which we advocate. This year alone, Investing Kids will provide services in all of Colorado's 64 counties and serve about 14,000 families. So you may be asking, indeed appropriately, how is it that we got here? So that's where I'm going to go into next, really appreciating the social challenge that you've heard about. The science to service gap, what is known to work is often not what is adopted. And of course, the implementation gap, which I'm going to lean into today. As a state-based intermediary, we really focus on the implementation space, and often find that what is adopted is not always used with fidelity. What is used with fidelity is not always sustained. And what is used with fidelity is not often at scale or scope to make a critical difference. So what is implementation? Great question. For those of you who don't know, it's a specified set of activities. And indeed, those activities put into practice are an activity or program of known dimensions. I appreciate how jargony that can be, and I hope I bring it alive in the coming slides. I actually was smart enough as the CEO of this organization to hire Dr. Amanda Fixon about 9 years ago, and she is our Vice President of Implementation and Programs. So I have a PhD here who focuses entirely on how it is that we ensure that our implementation of these evidence-based programs is aligned with best practice. I also want to acknowledge something that over, I would say, the last 6 to 8 years, Investing Kids has really been focused on. And as Pam spoke of, a focus of a recent paper that she did, but also really wanting to ground us in how important it is. It's not only critical to have implementation science leading the way, but equitable implementation. And so we take this definition from some colleagues and acknowledge that an explicit and an intentional integration of implementation science and equity is what attends to what is being delivered, for whom and under what conditions, and how delivery should be tailored to best meet the needs of the focus population. So again, smart enough to hire people brighter than myself. About 7 years ago, we brought on Dr. Erin Albrecht, who's the director of Investing Kids Equitable Evaluation Initiative, and really looking to build our capacity in this space as we deliver these programs. In partnership with community and local agencies, Investing Kids chooses to make it happen. I think that what's really important to recognize is that there is a lot of networking that occurs. There's a lot of communication, like our briefing here, but everyone on this call knows we need to go further than that in order to affect change. Helping it happen is where Investing Kids started. We really thought that educating communities about the availability of programs to local communities was going to be adequate, and really came to recognize that making it happen with the purposeful and proactive use of implementation practice and science was the only way to go. I want to use a very outdated example, but one that is so powerful in acknowledging the importance of implementation in addition to evidence-based programs. There was $500 million invested into a program back in the 90s, and ultimately it did not succeed in the field and was labeled an intervention failure. We very much see this as an implementation failure. We cannot drop these programs in communities without adequate supports and have an expectation that an effective program is going to have its intended impact. So I want to go to the next slide and talk about my favorite way to speak of Investing Kids work, the formula for success out of the National Implementation Research Network. And this is very intentionally a mathematical equation because anything times 0 is 0. So acknowledging that it takes all of these things to get to the socially significant outcomes. I've already talked about what Investing Kids innovations are, what the programs are we're choosing. But I wanted to provide this slide for those of you who are wanting to dive in deeper when we talk about what is a usable intervention and what is it that we as folks on the ground in these states need in order to be able to replicate programs from the program developers, from those who are initiating these programs. It's not just a great program with good outcomes, it's packaged in a way that allows us to successfully replicate. The effective implementation is where we spend a lot of our time at Invest in Kids, and I'm going to share a few slides talking about this. We focus a lot on the implementation stages. So again, a lot of jargon, so I want to acknowledge that, but really just if you focus on those circles, really deeply investing in an exploration process, moving into installation, and then acknowledging that full implementation takes 2 to 4 years, and really being in it for the long haul and having the long vision of what's possible is where we spend a lot of our time. This slide is a lot, and I want to acknowledge that. This is an example where we're taking the implementation drivers, the things that drive our success in the field, and applying the individual ways in which Investing Kids manifest this for one of our programs. But I think what's so important in this is recognizing that even folks who are in the implementation space often focus disproportionately on the competency drivers. They focus on choosing a program, training, and coaching, and they're out. And what's so critical is the integrated and compensatory nature of all of these drivers. And without all of them, what we see is a very short-term investment, and we don't ultimately get to the improved outcomes that we seek to achieve. The Joyce and Showers research, just again, acknowledging that, you know, if you go to a training and don't do coaching, it might as well have been a meeting because you're not going to absorb it in the way that you need to. And Investing Kids does all of the coaching as well. And then the enabling context, right? We all appreciate that there are a lot of different politics that are at play in local communities, a lot of different situations that will affect whether or not a program can succeed based on the broader context in which it is being delivered. I want to focus my last few minutes on acknowledging how Investing Kids has been successful in playing out not only the choice to have evidence-based programs in service to local communities in Colorado, but doing so through the implementation science approach has allowed for us to be very successful in identifying funding for the local providers to be able to deliver our programs in their communities. We have a very long way to go, but we have a strong foothold for a few of our programs. We are seeing investment in the sin taxes, obviously with tobacco and marijuana being dollars that are available in Colorado in service to the socially significant outcomes that we seek to achieve. We benefited tremendously from the American Rescue Plan Act to be able to launch some of our programs. Obviously, the maternal and infant and early childhood home visiting funding, these are approved programs. They're also approved programs for FFPSA. So there are opportunities that exist both at the state and federal level for these programs. And there has been a tremendous amount, tens of millions of dollars of private investment over the course of the last 25 years as well. As I mentioned, we're in all 64 counties with one or more of our programs. So that is a very political, that's sort of a a key for us. We don't have a single legislator that doesn't benefit from a portion of our work. And I want to round out by just acknowledging where Invest in Kids is going next. In 2023, we made a commitment to not only remain focused on our existing 3 programs, but to explore a more formalized approach of how we could, oh, what did I just do? Sorry, I think I just messed up my slide. I was trying to move someone's face off of the words, but we're just going to stay right here so we don't take up any more time. But we have something called the Building Rigorous and Equitable Evidence Initiative. And what I want to acknowledge in this is the importance to build evidence from the ground up. As we have dedicated ourselves to equitable evaluation, we have recognized that so many solutions exist among our communities, and that we may get to the level of evidence differently, but the ground up is as important as the top down. And so in 2024, this spring, we're just starting to pilot a program that is very much evidence informed, but does not have rigorous RCT data associated with it at this stage. We're the first and only US pilot, because Invest in Play's parent program is something that's coming to us out of the UK. And we're very excited to be a part of that pilot program and have built that program not only with the UK psychologists that established that, but also with our local communities, because we did 86 video vignettes that are showing all of the parent program strategies with English and Spanish speaking families throughout Colorado. And those were the ones that will occupy the 12 weeks of parenting program sessions for Invest in Kids. So that is where I want to pause and turn it over to my friend Ileana, but I'll let Denny do that. So thank you so much for your time, and thank you, Denny.
Thank you, Lisa. Such tremendous, tremendously rich information. Thank you so much. So I'm really pleased to introduce Ileana Lee. She's the case manager and team manager at Clinica Family Health, a federally qualified health center, where she provides resources, health education, and care coordination for the past 6 years. She has facilitated many programs in the community and has a deep skill set that includes teaching mindfulness and stress relief to adolescents. She is registered as a Colorado Department of Public Health and Education parent navigator and has experience as a youth development director, and has received proclamations for bullying awareness in Colorado and continues to serve the youth population. Ileana is a Nurse Family Partnership graduate and advocate within the clinic and the community.
Thank you. So I'm Ileana to be here, and I wanted to talk about kind of my idea and my experience with the program, and how I also share it with the community. So like they said, I do work at Clinica Family Health. I've been here for 6 years, and a big part of my job is to provide obstetric education during their office visits, as well as the initial intake. So my part with Invest in Kids is referring patients to Nurse Family Partnerships. When I first started, I didn't get much information because we were going through a transition. So I had a pamphlet, and I would facilitate these initial pregnancy groups, and I would have previous people that have participated in the program talk about it. So it would make me curious, and as well, it would make it easier for me to speak about it, not having the experience of being pregnant or even thinking about having kids, because me and my husband have always worked with at-risk youth. So then as time went by, and in 2019, I got pregnant for the first time at the age of 42. So I was a late bloomer with that. And we had just recently taken custody of a teenager. So it was a completely big difference in our family. It was during the end of 2019, going into 2020. So we had the whole COVID event coming as well. During that time, I had furloughed from my job, and I had requested for my primary care provider to connect me with the Nurse Family Partnership as well. When finally we got connected, the nurse reached out to me, and it was over the phone because there was no face-to-face interaction with anybody at the moment. So it was really nice to, number one, hear a warm voice at the other end of the line. Number two, it was she was very warm, very inviting. It wasn't weird at all. Um, but she made it easy to connect with her. And with that being said, during that time of COVID and all those uncertainties that were going on at the moment, it had affected me very much, especially because I have also gotten furloughed. So I didn't have any interaction with anybody else but my partner, the teenager we were taking care of at the time, and my dog. So Jessie, who became my nurse, was very helpful in helping me understand what was going on with my body, what was going on with myself mentally as well, because there was a lot of the uncertainty. She was very supportive, and I would say a lot of the time she was able to help me with focusing on my strengths. We would set goals every 2 weeks, and then follow up on it. And then even if I was coming up a little short, she would be like, well, we made it this far. This is what we're working on. So we would just continue. She was very helpful, and just thinking about everything that she taught me, all my questions, it was amazing. Then when my baby was born, it was a whole different, our relationship elevated a whole different step, right? A lot of times in our culture, people tend to give us old wives' tales and things that might be helpful for our child. So it was really nice to be able to reach out and get that medical advice from her, that was actually right, as opposed to well, maybe you should do this, right? So that was very helpful. And my son also was able to really benefit from it, because I could see we didn't get to meet face to face, so he was 1. So it was really hard because the socialing for him too. But she was able to help me with connecting me with programs, with a lot of things that I know as first-time moms we have concerns about. So then with me returning to work, she had made me so happy and so successful with my pregnancy and with my child, that it was easier for me to even talk about the program and refer more people into the program. So prior to being in the program, I would say maybe from 10 people, I would get 4 registered. And I think right now I have a success rate. Probably if I meet with 10, I'm pretty sure I'm going to get 9 of them. So yeah, that's part of me.
Thank you so much for sharing with us, Ileana, your very important experiences and how they're applying to your present work. It's really it's heartening. It's very heartening, and it just illustrates how these things do come to life in individuals and their own contexts. So really
Yeah.
appreciate that. Yes.
Thank
So,
you.
yeah, well, we have about 10 minutes for questions. There's quite a number of them in the Q&A. I will pick up a couple of them. We won't be able to address all, but we can always get back in touch with people to the extent possible. This is a question that we actually discussed in a meeting yesterday with Pew Zilly and our little breakouts. And I think it's important to acknowledge that there are these sort of barriers, the requirement that programs be evidence-based in order for them to be adopted, especially small programs that are evidence-informed, but perhaps not rated as evidence-based. And I think that's just an important distinction, but also important to recognize that evidence-informed is not insignificant, is not unimportant. And so she says it is a can't get there from here situation. Who would like to address that?
Can I briefly say something?
Of course.
I appreciate that question. And I just want to make it clear, and I think everyone, maybe I'm speaking to the choir about this. The interventions that exist on registries like Blueprints, they didn't come from what they were initially evidence informed. It's really important to think about evidence on a continuum. Lisa did an amazing job talking about what the continuum looks like on the implementation and scale up side. We didn't really touch on the adaptation part. That's all important. All of this is cyclical, and it starts with a program theory, a program idea, and then it's built. Evidence is built over time. So I don't want to underestimate the challenge it takes to get the funding and to get the support to build that evidence. But I also want to emphasize that evidence-informed is an important and necessary step in order to sustain. You can't get to an RCT stage, if at all, without that evidence-informed piece. They're all critical, equally important phases of the evidence continuum.
Can I just jump in?
Yes,
That's a great question, and I'm trying to think of a process of having people who have evidence-based informed programs and sort of taking them the next step. The United Nations Office on Drugs and Crime published a document that I think is extremely valuable and very pertinent. It sort of summarizes what we've learned over the last 30 years of what are the components of effective prevention interventions. And I think we can build on that to look at what those components are, and they fit, is what Pam was saying. There's a theoretical basis for a lot of what's been happening. And I think that we have to figure out a way of getting people who are working with evidence informed to be specific about what that is, and then look at what we know from randomized controlled trials, the gold standard. What pieces that might be missing that would support and reinforce what the people on the ground are doing, because I think it's the only way we can move forward. Randomized controlled trials are ridiculously expensive to carry out, and they take long to get. We have to come up with alternative designs to help communities.
yeah, very good. So just looking through the questions, there's a number of them that kind of speak to two well-aligned issues. Folks want to know how we can motivate political will for additional funding. So it's kind of a two-part, like political will, recognition of the value of prevention, recognition of what it takes to fund it adequately and sustain it and do it with fidelity, and ensure that it is adequately funded so that it can be evaluated and refined, and ensure that we're doing the right things, all that sort of thing. And so how do we increase the political will so that we can get to the point where we have more dedicated funding, more carve-outs, NIH, and in terms of the research, carve-outs for prevention, but also at other federal agencies, coming through the executive as well, but also through SAMHSA, through NDCP, through NIJ, through a number of different federal agencies. How can we increase, incentives to invest? Does anybody have any thoughts about that? Abby.
Denny, I was actually going to nominate you to answer this, because that's really what your prevention coalition is focused on. And all I will say as an add-on to what you're going to say is, political will is shaped by public views too. So we have to continue to reach the public with this news that we actually have programs that work and real people are doing them, and they can reach audiences of all different, backgrounds, ages, demographics. And the more that public stand behind these programs, the more political will can be generated as well. But I think you have a lot of expertise in reaching the policymakers directly too.
Just throw it my way, Abby.
Well, I actually want to just quickly let folks know about a newly formed caucus in Congress. It's called the What Works Caucus. And actually my Representative Pedersen in the state of Colorado is one of the 5 Congress people who has formed this. It's newly formed. Google it, check it out. Let them know what your thoughts are about how to scale these evidence-based programs. And now I'm going to kick it over to you, Denny.
Yeah. I mean, the Results for America helped to set this caucus up, and they are tremendously impactful in the federal space. So definitely key into Results for America's work. So there's a lot of ways to kind of tackle this. It's not easy, it's protracted, but I agree with Abby that there's a supply and demand equation here. The demand has to be there. So that means people need to understand what it is that we're doing in prevention and what the value added is, and also what the economic benefits are, which is incredibly important to get through to policymakers, that the return on investment is quite large once we really implement prevention properly. And to do that, I mean, I, you know, as a researcher and a activist and a, you know, a policy advocate and a number of other hats that I wear, I think that scientists and other experts, practitioners, people with lived experience, people who are running CBOs and so on and so forth, they need to speak with their legislators. We need to talk to our policymakers. We have to have a channel of communication. And it's very important to learn how to communicate, what the resonant messages are to get prevention across to folks, and to have the uptake. So there's like a lot of prongs to any given approach to increase political will, but the, you know, the National Prevention Science Coalition that's doing this briefing, and we do briefings on a regular basis. We talk to legislators on the Hill. We work with states, we work with local officials and a number of national organizations and so forth. And you know, there's over 1,000 of us all dedicated to the translation of this science to the public, to practitioners, to policymakers and beyond. And so it's really important that we use our voices and that we not be afraid to use our voices. We have rights to advocate. Some have limitations in lobbying, but we can all advocate. And what we're doing is educating and informing people who are in influential positions. Zilly.
One of our participants actually made a recommendation, which I think is fantastic. Lisa Heifmeister, I hope I pronounced it right. She suggests doing a 60-minute segment, and I think that's another way. I know when I was at night, I was trying to get Post and, you know, Times to try and do a piece in their magazine sections on prevention and what we were doing, and it wasn't sexy enough. But I think 60 minutes is a great idea. Something like that. We need to get it to the public. I think when the public, and particularly parents, realize that they have these resources, I mean, particularly now, I think kids are really challenged, and I think parents are really under a lot of stress to keep them safe and to just to keep them going. That this might be a great idea. I just want to point out that with the Triple P program, I don't know if you recall many years ago that Matt Saunders did in the UK had a television program on helping people, had a family that had issues, and that was part of the, you know, program. And then they'd have call-ins. And I always wondered if, you know, why can't we do something like that?
Yes. And so
A
I must
sitcom.
say, yeah, right. You know, I
Driven
must
by
say,
prevention.
yeah, we need to make it sexier for one thing, and we can. It's actually very exciting, focusing on what we can change to constitute prevention. Like people think, well, how can you measure what you're preventing because you don't see it? But we're changing the quality of life for people. We're changing their trajectories. We're increasing opportunities for people to be, you know, to be equitably served and to be able to access the levers in our society to be able to succeed. And so it can be very exciting if it's framed in a way that people really understand. But I wanted to mention what Child Trends is doing. Childtrends.org. Child Trends developed a series of news pieces that was very well funded, news pieces that were on local news channels all across the country about how to prevent child abuse. And it wasn't like this about child abuse. It was like, okay, breaking news. This new study just came out. Scientists, tell us what you found. And then it breaks and shows how families are doing with this information. They got to millions of people, and they did an RCT, a randomized controlled trial, for those of you who don't know, and found significant effects. And it was scaled. And so we're trying to work now on obtaining funding to have these like news bits on how to help your children, because it's local news. How do you help your children, your adolescents, divert their trajectories away from substance use, right? And so how can we do that effectively through local news just, numerous segments on how to do this, how to instill good parenting skills, effective parenting skills, how to manage your own self-regulation and all that. So I think it's a really neat idea. We as scientists have really kept away from using media the way we should. But I'll tell you all, the 213 people that are still on, I appreciate you. We did have hundreds that had to get off apparently, but oh, it went on my head. I was so excited. Oh gosh, darn it. I forgot what I was gonna say. It was really cool. I'll probably remember it in a minute. But yeah, I mean, I think we need to use, these channels to really get our, oh, that's what I was gonna tell you. We don't go into this field to make money. We don't go into science to make money. People in our field do not make money. We go into it to make a difference. And so we need to get out of our silos. And like I said, we need to use our voices, and we need to help people, compel them to want to put these things in action. And so that's one of the reasons why we do these briefings, to get people excited about all that's going on in the science, in the practice, in people's real lives, right? And so I think we have a really nice intersection of speakers here today that have gotten that message across really effectively, and I very much appreciate all of you. So I think we're good. I know there's more questions, and feel free to, we can be found. Senator Persaud's office, Alex, if I may, what policies have been presented in the past federally or in NYS do you recommend legislators to advocate for or look deeply into? I know Pam mentioned one legislation from a particular state, and Lisa mentioned a few grants in her organization able to secure in her state. But how would you like legislative offices to go about this? That's really important. So if Alex is still on, who wants to tackle this? Lisa?
Yeah, and I apologize because I have a hard stop in just a few minutes to jump, so I apologize. Alex, yeah, I think it's so state specific, right? Just appreciating Brian Baumgartner, I think he's still on this call. He's done a lot of work in the state of Pennsylvania. We've done a lot of work in Colorado. We would be more than happy to talk state policy with you. For us, we've approached it from a few different lenses, sort of generically from a policy perspective, and then going after program specific funding. So Alex, I wrote down your information when she made note of your question, and I'm happy to reach out.
Yes, and this is New York State, and Alex, we're available. This is, the briefings are not an end all be all. It's a window of opportunity to open doors and have this conversation. So please, Lisa and I, contact both of us, and we'll work with you. Very important. I'm so glad you're here. Well, I'm going to end it because I know some folks need to leave, and I apologize for anything we weren't able to address. But I hope you enjoyed it. You'll get a link to this. Everybody will get a link to the recording, to the slides, to the resources that we put into our website. And we'll look forward to having you at our subsequent briefings. We've got one coming up on the use of pharmaceutical settlement monies in the states that are not largely going to prevention, which we feel is, needs a little urging. So keep an eye out. We, appreciate all of you. Take good care.
Thank you, Denny.
Absolutely.